So he's going to present a case that we saw at Akron recently. So this is a 3-month-old male in the NICU. He's got intestinal failure and has a femoral Broviac in place for long-term IV access for TPN. And he's preparing for discharge in the next few weeks, but still needs that IV. And at the time of rounds one day, we notice this. So the outer sheath there is now broken. So there is some debate amongst the group about what the next best step would be, and thought it'd be great to bring to the update course. So
damaged Broviac.
A patient broken sheath on their Broviac is going to need central access at their upcoming discharge. What would you do?
So my question is, Alex, why did you put it in the femoral in the first place? Because if that might influence what you would do if there was a reason that drove you to put it in the femoral in the first place.
He had also had hemodialysis access site previously, so the femoral was the one that was selected for his. I think he had the hemodialysis line and the Broviac placed at the same time, pretty much.
Good question. I don't know the answer.
Why does he still need the line?
He still is an intestinal failure patient and needs it for a TPN.
Yeah. I don't know if you all can see the variability, but
a lot of variability, but
yeah.
About half will repair it with a kit. Some people talk about exchanging it over a wire, or placing a new one at a new site.
So the reason I asked Alex to present this, so I came on as Sal, and I'm a repair kit person. Yeah. One of the other surgeons said that, if this patient is going to need very long-term TPN, they would rather replace the line. My argument was that's exactly the reason why exactly. I wouldn't. But then the question is, well, how many repairs can you do? So we debated it. Eventually, it was repaired with a kit. But the question was, would you ever not do that? So it sounds like most people here. But it is impressive how many other people would not do that. So
and we saw one study that was looking at complication or infection rates, comparing the repair versus placing at a new site. And they had like 36 patients who had a Broviac in place and looked at how many ended up getting a repair. And I think there was like 96 repairs, and only one of them ended up getting a central line associated bloodstream infection. So like a 1% risk for infection with the repair. And most of them had multiple repairs. Like the median was 1.5 repairs per patient, and some of them even had like 10 repairs on the same line.
Yeah, you can keep repairing them. So you have a 6-year-old with AML that has positive cultures for Staph aureus through the central venous port. So what is the single most important way to prevent central venous catheter infections? Because I figured that we can't talk about central line complications without talking about the most common central line complication, which is central line infections. All of these things have been shown to impact central line infections, including dental care, especially in your hem-onc patients. So we actually have dentists who sold there to prevent central line infections in our hem-onc patients, preventing mucosal barrier infections and things like that. We talk about MBI collapses and non-MBI collapses, but it really is all the above. There is a lot of data to support this, and it's really hard to pick out if it's any one of these things that does the most in this patient or whatever it is. So this is just a pitch for the central line bundles that we all have and to follow them. And this is the kind of thing that for those of us in leadership positions, we're constantly harping on this and, making sure that people don't forget. It always amazes me when I start to see hand hygiene fall off. And, then we have to have a little new foam in, foam out campaign and those sorts of things. But it's a never ending battle. And it's really something that should be on the forefront of our minds, because to remember, the most common complication of central lines is a central line infection.
When you get an infection, what's your initial treatment?
So I didn't go into that here. Then, but if it's staph or something that's treatable, we'll treat it through the line.
So antibiotic lots.
Antibiotic. Well, so in high-risk patients, actually in our high-risk patients, we're doing antibiotic locks. So in patients that are short gut and some of our hem-onc patients, we're doing ethanol locks for to help. There's some evidence that those help. I don't know if everybody's doing that or not. Are you guys doing
Yeah,
that as
we
well?
do.
Yeah, and it looks, I've seen lots of
Yeah.
nods about people doing that. And we don't do that in every patient though, just high-risk patients.
What I was telling, I think Alex was on rounds with me yesterday or 2 days ago, and I was telling the team that when I was a resident or a fellow, we were taking out lines a lot. And I don't think I can't remember the last time I take out it's very rare we take out infected lines now because we can treat through almost all of them.
Almost all of them. So gram positives, you have about a 90% chance of clearing them. Gram negatives, it's closer to 50%. Fungal, it's
Yeah.
really hard. So
Yeah.
if so that's sort of depending on the risk of the patient and what you need and what you need to do. But usually gram positives we can clear. The others you a lot of times have to take it out.
Just want to make a comment about standardized dressing.
Mm-hmm.
What the surgeon thinks is the right dressing is not what nursing thinks is the right dressing.
That is true.
And so what happens is you put on the dressing in the OR that you think is the right dressing for that line. And as soon as they get to the floor, that's not the hospital approved standardized dressing and it gets taken off. That's how the line gets pulled out. That's how the line gets infected. So I'm encouraging everyone to work with their nursing leadership to come up with a standardized line.
Yeah, so Megan Durham, one of my partners, has spearheaded this, and she and some of the other folks, they actually took pictures of what the standardized dressings are and put them up in the operating room so that we can see what we're supposed to do. But if a lot in our case, we found that the recovery room nurses or the PACU nurses were like, you do all this stuff and it'd be all look nice and pretty, and then you go and they'd be changing it just because it wasn't the standard dressing.
We had the same problem, and the other problem we had that we had to address is that the standard dressing changed every 3 weeks, and communicating that to everybody was a challenge. So we've done the same thing on our central line cart. We have pictures of what the dressing's supposed to look like, and that is the dressing. And unless there's evidence to change it to something else, that's the dressing.